part of our academic series, which lies to look into latest evidences with regards to pediatric endocrinology. And as we know that every year there are around over 1,20,000 articles which are published across the globe. And if we do not keep pace with them, we will get left out. And very important to understand that when we're looking at those articles as to how it should change our practice in a clinical sense. So why do we need to do a literature review? And what we are looking at in terms of literature review is that we want to see whether the journal article that we are reading should be part of our clinical practice or not. So the key questions you will ask is whether the results that the article has published are really valid. Very importantly, they may be valid, but whether they are generalizable to our settings or not. So if you look at some data with regards to 780G, which shows that there is a significant improvement in terms of diabetic outcome, but if your patient cannot afford it, then it may not be generalizable to your clinical practice. We also want to see whether that journal article really represents a new development or it is an incremental phenomena. So whether it is a 0 to 1 or a 1 to 2 sort of activity. So you want to say that if it's 0 to 1, then probably this is something which is path breaking and things will change over time. And ultimately the aim would be to change your practice from that regards. All of you can go and have a look at our website, learning.growsociety.com, in which has got a lot of resources and courses related to pediatric endocrinology. We have got fellowship and postgraduate training programs. We do run a number of postgraduate lecture series. We also run the journal clubs and guideline reviews. Publications are available along with our mobile applications. So
trial of a randomized control trial, phase 3 trial using Dasiglucagon for the treatment of the congenital hyperinsulinism in children. This is the paper that has been published in JCEM in 2024, and the study has been done in USA using this Dasiglucagon for the treatment. Now, why we need to have this in a new agent or a agent that is not used till now in the treatment of the congenital hyperinsulinism? So the first thing is that we all know that congenital hyperinsulinism is a very rare disorder with having an incidence of around 1 in 50,000 in population. And there are existing, in terms of existing treatment, there are treatment like nutritional therapy, diazoxide, somatostatin inhibitors, and some uses some other agents like sirolimus also has been used. Now, most of these congenital hyperinsulinism are there is inactivating mutation of the ATP potassium channel is present, and the existing treatment in terms of the diazoxide that is very not well established in these cases. Also, many patients experience persistent of hypoglycemia and requires nutritional support even after treating with medicinal therapy. Not only that, even after the surgical therapy in terms of the near total pancreatectomy or subtotal pancreatectomy, there is 40 to 50% patient still remains hypoglycemic after that, and they sometimes manifest as severe disorders like diabetes. So we need to have something that can be change this kind of complication in the patient. So who are the treatment protocol who are the patients in this treatment protocol? They are infants of 3 to 12 months of age who had a following inclusion criteria. The body weight was greater than 4 kg with a documented diagnosis of congenital hyperinsulinism. And they were previously for 2 weeks, they are given a blinded CGM by which and also SMPG to see there are more than 3 episodes of hypoglycemia per week. So these 3 criteria must be fulfilled before they are enrolled into the study. In the exclusion criteria, there are patients who has been treated with subtotal or near total pancreatectomy, and those patients who had developed or required exogenous insulin and had a HbA1c level of more than 7 has been excluded from the study. Now from this age group, from the coming on to the flow chart of this study, how this study has been done. This is a randomized controlled trial, open label trial, which is done for 8 weeks of duration and has a long extension for another 4 weeks. So there were 32 children total present in our study, and which was randomly assigned 16 into 16 in the two groups. One group is given only the standard of care treatment for the first 4 weeks. The standard.
Tell us first, what is dasiglucagon?
Okay, so dasiglucagon is a novel glucagon analog that is.
So what is the novel about it? What is its half-life? Why are we using it?
I don't have much here about this thing.
That is the main thing, because when you're looking, it's not just about the study. So when you are saying dasiglucagon, this is a longer acting analog of glucagon. There have been people who have used glucagon as pumps also for long-term control when there is a diazoxide refractory hypoglycemia preventing. So when is it used? When you want to prevent pancreatectomy. So somebody who is, of course, diazoxide responsive, you're not worried about that. But somebody who is diazoxide resistant, in that case, and you don't have a focal lesion, you need a total pancreatectomy. So people have used glucagon being delivered through the infusion pump. And that is going to then be giving you stable control. And what are the problems of glucagon injection?
There could be nausea, vomiting, like
Nausea, vomiting, rash may develop.
Yes,
so
skin
like
lesions.
glucagonoma, if you look at, there are a lot of
Respiratory infections are much more.
there. So all those things are there. So this is a novel agent. So you need to really tell the audience about what really it does. Otherwise, how will they understand? So dasiglucagon is a longer acting, safer agent of glucagon.
So in the first group, they had been given the standard of care treatment for 4 weeks. In standard of care treatment, there is a nutritional therapy as well as diazoxide, and in some patients, lanreotide like serotonin, lanreotide somatostatin receptor analog has been used. And in another group, there has been dasiglucagon plus the standard of care treatment given for the initial 4 weeks. In the later half, for the next 4 weeks, all the patient has been shifted to the dasiglucagon and the standard of care treatment. And after completing the 8 weeks, they had been followed a long-term extension trial for the dasiglucagon and standard of care treatment. Now, so as I had already said, this is a novel glucagon analog, and in our study, it was started with a dose of a 10 microgram per hour, which has subsequently increased to up to 70 microgram per hour. And the major side effects were nausea, vomiting, skin reactions, and some respiratory illnesses that has been present in this study. So we compare the baseline characteristics of the patient in the both the group, and we can see the overall mean age was 4.3 years. In cases of both the study, the male-female ratio was almost 50% with 16 patient in the male and 16 female patient. Height and weight were very much comparable in the both the groups. Now in standard of care treatment, as you can see that the somatostatin analogs and the diazoxides had been used, and also there is use of sirolimus in one patient in this study. Now coming on to the major hypoglycemic events that has been happened during this treatment. So it has been seen that initially for the first 2 weeks, the patient was put on CGM to see for the baseline level of hypoglycemic episodes that has been occurring or not. Also at the same time, patient was unblinded to the self-monitoring plasma glucose level. During the, we can see the self-monitoring plasma glucose level, plasma glucose monitoring incidence of hypoglycemic events were decreased in both the incidents, but they are not statistically significant. But when we compare with the CGM data, we can see that there is a statistically significant reduction of the mean number of hypoglycemic events per week in the as in the hypoglycemic events as well as in the severe hypoglycemic events.
So what you are seeing is that if you're doing SMBG, you are not picking up 75% of hypoglycemic episodes. So if you say there are 36 in the one with CGM, only 8 are there in the SMBG. So the SMBG should not be considered, I think, now.
Yes.
So what they're trying to say is that you are able to pick up more. So when you're picking up more, you will find more differences in that regards. Now, what is interesting is that as the duration of treatment went off from baseline to week 2 to 4. Okay, so 13.9 became 8.5 and 18.2 became 14.
Yes.
Yeah.
So not only CGM value has shown the significant improvement of decreasing the hypoglycemic events, also it has shown other kind of hypoglycemic, that severe clinically significant hypoglycemic episodes has been reduced. And also an important parameter was there was a decrease in the nocturnal hypoglycemic episodes in cases of CGM value in this study with dasiglucagon and standard of care therapy.
Overall, the time below ring, if you can say, it become like half.
Yes.
So earlier they were spending, that would be more important from my perspective, 20% was spent below range. Now it has become 10. And 6% was severe hypo and 3% it became.
So this is the graphical representation of the self-monitoring plasma glucose versus the CGM detected hypoglycemia, and we can see the hypoglycemic episodes were much lesser in the 2 to 4 weeks of duration in the first part of the study with a p-value of 0.0029 per. Now, in comparison with the adverse effect with dasiglucagon, there are incidences. There are incidences of some rashes, eczematous rashes was present, some episodes of upper respiratory tract infections, as well as the most common side effects were the vomiting, nausea, and diarrhea in the dasiglucagon group in comparison to the standard of care treatment. So they had concluded that dasiglucagon.
What is most important perspective from that regard? How many patients were you able to salvage from pancreatectomy? These will be the long-term questions. Like this 4 week, 8 week is just about getting the initial data in. But what we are interested in is, okay, you have a diazoxide refractory neonatal hyperinsulinism who is not a focal form. You are planning to post for surgery. Can we use dasiglucagon for a long time to prevent that? How was it administered?
It was administered by a subcutaneous infusion pump. Actually,
infusion pump only. So earlier we had the conventional glucagon and now we have got this glucagon. So the biggest question is whether you are able to salvage the pancreas in that setting, because many of these patients did not have had pancreatectomy by that time. So carry on.
So it has been concluded that dasiglucagon treatment has been associated with marked and clinically meaningful reductions in the all measures of hypoglycemia recorded by the CGM. They had also concluded why this CGM value has much more detection, because they had told that it is a way of intervention, that in SMPG we do not take 5 minutes of interval of blood glucose level and it's number of glucose. Though they have told that CGM value may not be that much comparable with SMPG, still it is better in picking up.
Many times you will pick up more, so that is the logical thing.
And
so what would you recommend?
Sir, it can be recommended considering the number of
so before you
decreasing the hypoglycemic
surgery, yes, this could be an option which should be definitely considered. Now, of course, you don't know how long will you treat.
Yes, and also there is adverse effects are not so much severe as we can see in the previous study, but here
because the adverse effects of pancreatectomy will be exocrine pancreatic insufficiency,
like diabetes
deficiency that becomes too much.
So we conclude our study that it is a prospective randomized control trial with there is monitoring in terms of the blinded CGM that has been given to the patient, as well as unblinded self-monitoring of plasma glucose. And the population was taken as an infant between 3 to 12 months of age. So is it generalizable? Yes, it can be used in cases of infants with congenital hyperinsulinism, and this intervention is feasible. The limitations were in this study were that there is no standard care of treatment was advocated to the patient. That means there is no standard drug was given to the all patient of in this study. We have used multiple drugs as a standard of care, and also
because there is no standard of care.
Yes.
So in those cases, the standard of care is pancreatectomy. So they're trying to salvage. So of course, you can't say stop it. So this will be a problem in these trials.
And there is also the time and the frequency of SMPG that has been done. That is also a questionable thing, whether they had done in the proper time, they had done in the periods of the hypoglycemia was also questionable. Now the impact, so CGM detected hypoglycemic episodes were much improved in comparison to the standard of care in case of dasiglucagon treatment, and with a very minor adverse effect that is here used. The important thing in this study was the 30 among the 32 patient, 1 patient was further continued for the long-term extension of the study, and they had concluded when this study result will come, we'll get to know whether the long-term effect of the dasiglucagon is important in cases of congenital hyperinsulinism or not. So that's it.
I think this is a very, very interesting study. And this brings us to a very important fact that when you have established therapy, which is safe and effective, it is very difficult to replace it. So when you say, okay, we have got bisphosphonate, which has been used for 20 years in OI, I got this new agent, you just start using it, there will be a lot of resistance. You have got testosterone, which is safe, effective. So why would suddenly I start using aromatase inhibitors for induction? But here people are not comfortable with pancreatectomy as a primary modality. So even if you have something which has got certain side effects, they will prefer using it rather than going ahead with that.